Women's mental health is a special area of a psychiatric practice that examines how a biological, psychological, social, cultural, and reproductive factors can influence psychiatric disorders across the lifespan. Women experience a unique psychiatric consideration related to puberty, menstrual cycle, pregnancy, postpartum period, infertility, pregnancy losses, lactation, menstrual, menopause, and hormonal transition. Psychiatric disorders may present different in women due to hormonal fluctuation, difference in stress response systems, stress, social roles, trauma exposure, caregiver responsibility, healthcare access disparity and barriers. Perinatal psychiatric focus especially on psychiatric care during the pregnancy, postpartum period, lactation, and transition to parenthood. Psychiatrists must be able to balance maternal mental health, fetal infant safety, evidence-based treatment, and patient autonomy. And untreated psychiatric illness during the pregnancy can result in a significant consequence of the mother, pregnancy outcome, infant development, and family function. After completing this video, you will be able to learn and describe sexual and general consideration in psychiatric disorders, understand the reproductive hormonal influence in mental health, assess psychiatric illness during the pregnancy and postpartum, assess psychiatric illness during the pregnancy and postpartum, diagnose and treat mood and anxiety disorder, diagnose and treat perinatal mood and anxiety disorder, recognize postpartum psychosis as the psychiatric emergency, evaluate the medication risks and benefit during the pregnancy and lactation, because the medication can affect the fetus. Many medications go through the milk and that can or in the pregnancy it can affect the fetus or the child, because the medication can transmit through the milk or placenta barriers. Provide trauma-informed reproductive care, psychiatric care. Develop evidence-based treatment plan for women across their lifetime. Women mental health is steady and clinical treatment is psychiatric conditions influenced by the biological, sex, reproductive physiology, gender-related experience, social environment, and cultural factors. Psychiatric disorders may differ by the prevalence, age of the onset, symptoms, presentations, treatment response, and risk factors. Disorders more common diagnosis in women are major depression disorders, anxiety disorders, postpartum disorders, eating disorders, somatic symptoms disorders. Disorders require special attention in women include perinatal depression, premenstrual dysphoria disorder, postpartum psychosis, which is a medical emergency, psychiatric emergency, perimenopause mood disorders, neurological of the female reproductive psychiatric include the hormones, include mood regulation, stress response, sleep regulation, cognition, and mood process. Estrogen affects serotonin system, dopamine signaling, neuroplasticity and adaptation, mood regulation. Changes in estrogen levels may influence vulnerability to mood symptoms. Progesterone, which is hormone, progesterone affects GABA signaling, anxiety regulation, sleep regulation. Rapid hormonal changes may contribute to psychiatric symptoms in a vulnerable individual. HBAXS, which is hypothalamus pituitary adrenal axis, the stress response system influenced by the trauma, pregnancy, chronic stress, which mothers who are pregnant go through, hormonal changes, dysregulations of the hypothalamus pituitary adrenal axis may contribute to depression, anxiety, and trauma-related symptoms. Psychiatric assessment in women in mental health is a comprehensive assessment that includes psychiatric history, reproductive history, medication history, social assessment history. So psychiatric history of the women, you want to assess the mood symptoms. You want to assess anxiety symptoms. You want to assess trauma history. You want to assess the eating behavior, eating disorder behavior, substance usage, prior psychiatric episode if the patient have a prior psychiatric history or episode, reproductive history include important areas such as menstrual history, pregnancy history, miscarriage, infertility, pregnancy complications, birth experience, how do they had experience trauma, breastfeeding history, because you want to know if they are going to breastfeed the child and you want to assist the risky through the milk to this medication. Medication history, you want to assess the previous medication response, how that affected the patient and the fetus. Medication, if she have been taking medication when she was pregnant, medication discontinuation history that caused by the pregnancy or symptoms or mood disorders, you want to assess that. You want to evaluate social, you want to assess the social, and you want to evaluate the relationship support if the patient have, or the woman who is pregnant or breastfeeding have support. Parent stress, she's going through stress when she's becoming a parent. You want to assess financial stress. Does she has a financial stress? Safety, does she safe and her child is safe? Cultural experience, you want to also assess that. Major depression disorder in women. Women experience a higher of the depression compared to men. Why is that? Risk factors include hormonal transition, trauma history, interpersonal stress, caregiver burnout, domestic violence, poverty, chronic illness. Clinical presentation include women may present with sadness, tearfulness, anxiety, irritability, fatigue, excessive guilt, sleep disturbance. So you want to assess those symptoms. You want to evaluate the severity of the depression, functional impairment, how that affected her, how that affected the child, how that affected her responsibility, how that affected her sleep. You want to assess also suicidal risk and violent to the child, violent to her. Pregnancy status, you want to assess the pregnancy status. Medication history, have she been taking medication when she was pregnant or she's taking now? Does she require psychiatric medication at this time? Premenstrual disorders. Premenstrual disorders. Premenstrual dysphoria disorders. Premenstrual dysphoria disorders involves several mood symptoms that occur during the lactation phase of the menstrual cycle. Symptoms include mood, liability, irritability, anxiety, depression, decreased interest, appetite changes, sleep changes. Symptoms improve after menstrual begins. Cause significant impairment. Diagnosis requires prospective symptoms tracking, circular symptoms pattern, and functional impairment. Treatment: you want lifestyle interventions, psychotherapy, medication treatment. So the lifestyle interventions include exercise, sleep regulation, stress reduction, and psychotherapy. Its evidence support psychotherapy is cognitive behavior therapy. Medication is SSRI may believe to be effective and may used continuously or during the symptomatic phase. Pregnancy and psychiatric disorders. Pregnancy involves major biological and psychological changes. Psychiatric risks during the pregnancy include: pregnancy may be associated with new psychiatric symptoms, relapse after the medication discontinuation because the risk to the fetus or to the baby, increased anxiety for the role changes and hormones, trauma-related symptoms. Clinical principles include: pregnancy does not protect against the psychiatric illness. So the pregnancy is not going to protect you from the medical illness. Untreated illness may create a risk for mother functioning, perinatal care, pregnancy outcome, and infant development. Medication management during the pregnancy. Treatment decisions require individualized risk-benefit analysis. Consider severity of the illness, history of a relapse, medication effectiveness, pregnancy stage, alternative treatment. If you can have alternative treatment that is not going to affect the fetus or the mother, and it can improve their quality of life and improve their symptoms, that is what you want to look for. General principles include: avoid discontinuation, stopping effective medication suddenly may increase the relapse risk. So you want to avoid quick discontinuation of the medication. Use evidence-based decision making. Consider currently current evidence. Consider patient preference. Consider clinical safety. Use the lowest effective dose when medication is indicated for pregnancy and breastfeeding mothers. Perinatal depression is defined as depressive episode during the pregnancy, after the child birth. Risk factors include previous depression, previous postpartum depression, anxiety disorder. If the mother used to have anxiety disorder, it will increase at this time. Trauma history, if she had a trauma history, limitation social support, that will increase the depression. Unplanned pregnancy increases the depression, and relationship conflict can increase the depression that the mother feels. Symptoms include persistent sadness, loss of interest, exclusive guilt, anxiety, sleep disturbance, difficulty bonding to the child, infant, and suicidal and violence thoughts. You want to use the screening tools. Common screening tools include postpartum scale, postpartum depression scale, postpartum depression scale, parental health questionnaire depression screening scale. You want to use those. Treatment include psychotherapy, medication treatment, and psychotherapy include effective approach, include cognitive behavior therapy and interpersonal psychotherapy. Medication include antidepressant medications, and it depends on the severity, history of the depression, patient preferences, and risk and benefit reassessment. Perinatal anxiety disorder. Anxiety disorders are common during the pregnancy and postpartum. Presentations include excessive worries, panic attacks, intrusive thoughts, hypervigilance, and sleep disturbance. OCD symptoms may include intrusive and unwanted thoughts, fear of harming the infant, excessive checking behavior. Important: intrusive thoughts do not automatically indicate intent. Assessment must distinguish between obsession, psychosis, and actual intent. Postpartum psychosis is a psychiatric emergency. It usually occurs soon after the birth of the baby, often within the first week of postpartum. Risk factors strongly associated with biological disorders, previously postpartum psychosis, family history of bipolar. Symptoms may include mania, severe insomnia, confusion, delusion and hallucination, disorganized thoughts. Clinical management requires immediate psychiatric evaluation, safety assessment, protection of the mother and the fetus. Consider hospitalization. Bipolar disorder and reproductive psychiatric. Bipolar disorders requires specific mention because the pregnancy can affect mood stabilization. Medication change may increase the relapse and risk of the symptoms. Relapse risks. Clinical considerations include assessment of the mania, history of mania if the patient had a mania before, previous postpartum episode, medication response on the previous, if she has a previous bipolar disorder, family psychiatric history, you want to assess those. Medication considerations, you want to evaluate the risk of the medication exposure to the fetus or the infant. You want to also evaluate the risk of untreated bipolar disorder for the mother. You want to also evaluate the risk of postpartum relapse. Trauma and mother mental health. Women experience a higher rate of trauma exposure. Examples include childhood abuse, sexual trauma, domestic violence, reproductive trauma. Trauma-informed care principles include safety of the fetus and the mother, trust, collaboration, choice, empowering the mother, intimate partner violence and psychiatric care. Intimate partner violence and psychiatric care. Intimate is associated with depression, anxiety, postpartum. If the mother is going through that intimate partner violence, it is associated with depression, anxiety, because the woman is vulnerable place, and then if she's going through intimate partner violence, that increase the depression, anxiety, postpartum depression, PTSD, substance usage, suicidal risk. So you want to assess and ask preferably and safety about relationship safety, physical violence, emotional abuse, control, fear. Infertility and pregnancy losses, reproductive loss, reproductive loss may produce grieving, depression, anxiety, trauma symptoms. Treatment include supportive therapy, grief counseling, depression and anxiety treatment when indicated, postpartum, and menopause. Menopausal transition involve hormonal change effects that can affect the sleep, mood, cognition, and anxiety. Common symptoms include irritability, mood changes, insomnia, and emotional sensitivity. Assessment include differentiating normal transition symptoms, major depression disorders, anxiety disorders, medication causes. For eating disorders in a woman, eating disorders frequently affect women. Major disorders include anorexia nervosa, bulimia, binge eating disorder. Psychiatric considerations include you want to assess the body mass index, body image, you want to assess eating behaviors, medication compliance, suicidal risks. Psychiatric psychopharmacology across the reproductive lifespan. Medication decisions requires individualized assessment, shared decision making between the patient and the provider, monitoring the side effects, monitoring the labs that require on the medication. Consideration include pregnancy. You want to weigh the risks and benefit for in the pregnancy, lactation, in the lactation stage, hormonal therapy, menopause treatments, and non-pharmacology, medical comorbidity, if she has a different disease than psychiatric, if she has a medical conditions or psychiatric conditions. Lactation, breastfeeding considerations include medication transmit breast milk to the infants, and that can create risks to the fetus. You want to also consider the infant age, how this medication is going to affect. You want to assess the maternal psychiatric stability, and the clinical principles include healthy mothers is essential for healthy infants' development. Untreated severe psychiatric illness may also negatively affect the child. Integrate perinatal mental health care. Effective care include collaboration with obstetric provider, pediatric provider, primary care therapists, social workers, lactation specialists. Clinical case study that I have for you here is a 29 years old, present at 3 weeks after delivery. And the symptoms include severe insomnia, racing thoughts, and suspicious toward family and reports hearing voices. Wow. Family reports she has become completely different since the baby was born. You want to assess the important factors such as recent breath, severe sleep disorders, psychosis symptoms, behavior changes, and the clinical formations include possible of the postpartum psychosis that require immediately safety evaluation and psychiatric emergency management. The treatment plan include urgent psychiatric evaluation, assessment of the risk to self and the fetus, higher level of care if indicated, medication treatment, and family support. Thank you for joining me. Please subscribe and join me again. Thank you.